My name is Dr. Raj K, and this is ECG Kit Portal. Alright, pulmonary embolism, a clot that can kill in the next hour. Now, most of the time, ECG looks completely normal, but sometimes it leaves behind 5 hidden clues. Subtle, easy to dismiss, but if you can catch them, you can save a life. So today, let's uncover what those 5 signs are, and most importantly, why they appear on the ECG. But to read the ECG properly, we need to rewind. What's actually happening inside the lungs when PE strikes? A clot lodges in the pulmonary arteries, and the pressure inside the lungs suddenly skyrockets. The right ventricle have to pump against that wall of resistance. Imagine pushing a door that suddenly locks shut. That's the RV, stressed, overloaded, and struggling. And the ECG is basically the RV's diary of that struggle.
Here's your heart on the screen. Now you have got 4 chambers, the right atrium, the left atrium, and down here the right and left ventricle. Now pay attention to this side, the right ventricle. This is the one pumping blood into the pulmonary arteries. And where do those pulmonary arteries go? Yeah, straight into the lungs, carrying blood that is low in oxygen, or what we call the desaturated blood. So, the blood coming from the body into the right atrium drops down into the right ventricle and boom, get pushed into the pulmonary arteries. From there, it will spread into the lungs for oxygen exchange. Meanwhile, over here on the left side, blood is coming back oxygen rich into the left atrium and left ventricle and finally goes out to the body. Now, what happens if a clot get lodged right here in the pulmonary artery? Think of it like a roadblock on the main highway from right ventricle to the lungs. The right ventricle, which is pumping, trying to push the blood to the lungs, but suddenly it's pressing against a wall. The pressure start to build up, and because less blood is making into the lungs, less oxygen is being picked up. So oxygen levels in blood start to drop. At the same time, the left side of heart isn't getting enough oxygen back from the lungs, which means your blood pressure can fall. So the body tries to compensate only it knows by speeding up the heart rate. So what's basically happening is when the blood pressure is dropping, our sympathetic nervous system get activated and it releases catecholamines like adrenaline, which directly affect the sinoatrial node to increase our heart rate. That's the reason we are seeing the sinus tachycardia on the ECG in the pulmonary embolism. So the very first sign you'll notice on the ECG is sinus tachycardia, the heart speeding up, trying to keep up with the low oxygen and failing pressure. Now here's the thing. The right ventricle under a lot of stress here. It's pumping hard against that blocked pulmonary artery, which is gonna strain the walls of the right ventricle. That's the reason we are seeing this stretching and bulging of the right ventricle. This is where we talk about the classic S1 Q3 T3 pattern. Now, because the right ventricle is pushing against the blocked pulmonary artery, it starts to dilate and strain. The electrical forces of heart actually shifts. And here is what it does on the ECG. Normally, the left ventricle dominates the ECG, but now the right ventricle is stressed. It pull up the axis more towards the right. So in lead 1, instead of the usual positive wave, you end up with a deep S wave because the main depolarization is moving away from lead 1. Meanwhile, in lead 3, the vector is pointing more towards it. That's why you pick up a Q wave and a T wave inversion there. Classic sign of right ventricular strain pattern. And when the strain gets worse, you also see T wave inversion in right precordial leads from V1 through V4, again because the right ventricle is overloaded and struggling. So S1 Q3 T3 pattern isn't just a random ECG trick, it's an electrical footprint of ventricle under pressure. Now let's zoom into the right precordial lead, V1 to V4. When the right ventricle is under strain, it starts to show electrical changes here. You'll often see T-wave emergence across these leads. Sometimes you might even catch ST segment depression. Now, why does this happen? Because the right ventricle is suddenly working against a high pressure, its oxygen demand shoots up, but supply is limited. Remember, blood isn't reaching the lungs properly for oxygenation, and this creates a mismatch, sort of ischemia type pattern on the ECG. So we are going to see those T waves and STT changes. It's one of the clearest fingerprint of right ventricular strain pattern in pulmonary embolism. So we have seen three signs up to this point: sinus tachycardia, the classic S1Q3T3 pattern, and the right ventricular strain pattern, which means there will be T-wave inversion in lead V1 to V4 or the precordial leads. Normally, the left ventricle dominates the heart electrical axis, but when the right ventricle dilates, it pulls the current towards the right. On the ECG, that means more positive signal in lead pointing to the right. Which lead point to the right? Yes, lead 3. And more negative in leftward leads like lead 1. So if you see right axis deviation in patient in sudden dyspnea, think the right ventricle is dilated or getting dilated and is now the main shape of electrical axis. And that's another footprint of PE. And finally, in some patient with the right ventricular strain pattern, the strain is so extreme that it disrupts the conduction system itself. The right bundle branch, which is located in the right ventricle, is stretched and overloaded, and this slows down the conduction. What does that mean? In the ECG, you are going to see the classic wide QRS complex with the RS-R1 pattern in lead V1, the sign of right bundle branch block. So when you see new RBBB setting of hypoxia, chest pain, that's not random. To put it all together, there will be sinus tachycardia. The body is firing adrenaline, trying to pump faster. There will be S1Q3T3 pattern, which is typically due to the axis shifting to the right, leaving its fingerprints. There will be T-wave inversion in lead V1 to V4 due to right ventricular strain and ischemia. And there will be right axis deviation. The heart electrical axis is pulled toward the right, and in some cases there will be new right bundle branch block due to the conduction fiber breaking under pressure. Remember, no single ECG sign rule out PE. For that, we need the pulmonary angio, Turico, and some other test to confirm the diagnosis. But when you put the physiology and these patterns together, you can catch what most people need. Thank you for today, and see you in the next one.
My name is Dr. Raj K, and this is ECG Kit Portal.